Hello, everyone. Welcome to your online lecture for the functional anatomy of the lumbar and thoracic spine. Pretty excited to be diving a little bit deeper into the vertebral column. As we just finished kind of thoracic and abdominal injuries, we'll continue to talk thoracic, at least posterior thoracic spine, and we'll move into lumbar injuries, which will make up a large percent of pathologies that you'll see in the clinical setting. But before I can even start with the lumbar spine or thoracic spine and pathologies or even anatomy, I kind of wanted you all to really think about the hips and the pelvis and the lumbar spine in particular being a functionally integrated unit. And what do I mean by that? Exactly. What I mean by that is that if you have dysfunction in any of those joints, so dysfunction to the pelvis will also create a compensation at the lumbar spine and at the hip, right? And so similarly, if we have a hip injury, that will create some sort of dysfunction or compensation at the pelvis and the lumbar spine. So they are this functional integrated unit. It's the first time in the class where we really see the kind of merging of your lower extremity knowledge with your upper extremity knowledge. And isn't that ironic that it's happening right at the lumbar spine, where we can see that forces are going to be starting to get transmitted from the lower limb to the upper extremity. So as you start thinking through pathologies to the lumbar spine and pathologies to the upper extremities, we have to start thinking about the pelvis, the hip, and the lumbar spine being this integrated unit known as the lumbopelvic hip complex. So the lumbopelvic hip complex, for review, is going to be comprised of the lumbar spine. The lumbar spine has 5 vertebrae within it. And then in addition to that, it's going to be comprised of the right and left ilia, and then the right and the left femur, right, or the hip. And so if we think of them as an integrated unit, anytime we have a patient who comes into our clinic and is complaining of low back pain, we should assess the entire lumbopelvic hip complex region, right? So that assessment shouldn't just involve an assessment of range of motion at the lumbar spine, but certainly should involve an assessment of pelvic rotation, for example, or pelvic movement or gliding or sliding in the frontal plane, or maybe pelvic rotation. Similarly, we should look at how much mobility or lack of mobility the patient has at the hip joint as well, because we know that maybe a decline in mobility may increase the need for the lumbar spine to be even more kind of mobile than it is, creating shearing forces here. So we can see this lumbopelvic hip complex doesn't get a whole bunch of credit, and oftentimes your older clinicians may not think about the fact that the lumbar spine, even though it's generating pain, that pain may be as a result of something distal. So something that's happening at the pelvis or something that's happening at the knee that we fail to evaluate. So I'm hoping that you all, new clinicians, are just thinking differently. So let's think about chain reaction forces. We have superior gravitational forces that happen, right? And that's just as a result of body weight, right? As we're standing upright, the head is sitting on the cervical spine, and indirectly gravitational forces are being transmitted inferiorly, right, or distally. But then as upright human beings, we know that the first point of contact with the ground is going to be the foot. So as soon as we step out of the bed, the foot hits the ground and the body gets to moving. That's what I say, right? Another way to say that, probably more scientifically, is that anytime the foot hits the ground, anytime the foot is in contact with the ground, we have kinetic chain reactional forces or gravitational forces that are going to be transmitted proximally, right? So we have these gravitational forces occurring superiorly from the head sitting on the cervical spine that are moving distally. But then we also have these ground reactional forces that are being transferred from the lower limb, right, to the upper extremity. And most of those forces, if they're coming from the proximal portion, which is the head resting on the cervical spine, or they're coming from the distal segment where the foot is in contact with the ground, they really converge at a joint central to everything. And that joint is known as the, what is it? You got it, the SI joint, right? It's kind of like what we would call is the fulcrum or the relay station or the traffic circle, right? So let's think about a fulcrum. When we think about the fulcrum, I'm going to bring in this sacrum right here, right? Imagine the sacrum has ilium sitting on each side and the hips are coming off. But the sacrum really for me is a fulcrum site. I like to think of the sacrum as kind of a teeter-totter, right? It's the center part or it's the fulcrum piece. And then in the teeter-totter, what we have are people who sit on each end, right? Those people sitting on each end of the fulcrum most often are either going to be the ilium, right? Which either maybe have a superior glide or an inferior glide if there's contact with the ground versus non-contact with the ground, or that fulcrum can be the upper extremity, right? Our arms. So we have this kind of fulcrum that exists with the lumbopelvic complex, right? So we're looking here, the sacrum, particularly the SI joint, is at the center of that fulcrum. You have the ilia sitting on it. And as we move or as we walk, right? As we move or as we walk, and as those ilia shift positions, you can see that in that center image on the slide, they glide or slide or rotate or nutate, right? Across the sacrum, creating movement, right? Or transferring forces through the sacrum to the vertebral column. We can also think of it as a relay station. How many of you have ever called 911? When you call 911, you get connected to a dispatcher, right? And then depending on the type of patient case, if it's a mental health case, you may be, your call may be transferred to mental health services. If it's a fire, your call may be transferred to the fire department. If it's maybe some type of poison case, then poison control center, et cetera, et cetera, et cetera, et cetera, right? You'll get relayed to the appropriate dispatcher who's trained to help you. I'd like to think of the lumbopelvic complex like a relay station as forces get transmitted either from the distal segment or from the proximal segment. Those forces then get relayed to specific areas in the body, right? And I would like to think, okay, forces from the distal segment, the ground up, get transferred, and let's think about a throwing athlete get converted into energy, which may increase velocity of a pitch, slow down velocity of a pitch if there's injury, right? Forces from the superior segment, which are more gravitational in nature, might get transmitted to the cervical spine. And if it sits there and doesn't travel more distal, can create like a neck pain in a patient. Last but not least is a traffic circle. We can consider the lumbopelvic hip complex like a traffic circle. Have you ever gone in a roundabout? Either you keep going in a circle, or what's it going to do eventually? It's going to dump you off or let you out onto the next street that you need to get to. Oftentimes with forces, as they move from the ground up, they hit that traffic circle, which is going to be that sacral base. And either they sit there on the sacral base and cause lumbar spine pain, right? Or they get transmitted to, let's say, the ribs, for example, or the scapula, where force is then generated into energy, and that energy is most often velocity based, right? So we can see how the articulation between the pelvis, the hip, and the lumbar spine really create what we call is a functional unit. And so any dysfunction to this region most often will create some sort of movement dysfunction or force movement inefficiency, which could lead to injury throughout the actual chain itself. So I hope that makes sense. I'm going to forward us to our next slide, where I really wanted to add this in. This isn't a textbook thing, but I think of it as a clinical pearl. Many of us may wear a necklace or some type of bracelet, and most often those are on some type of like chain, right? And if you look at the chain very closely, you can see that it has small little integrated links, which is responsible for creating the beautiful necklace that we often see. The body as such is a chain, and that chain has links. Those links are different joints. You can see that on the slide. The ankle joint is a link, the knee joint, hip, lumbar spine, thoracic spine, cervical spine, the skull, all links that are connected to one another. So anytime there's dysfunction, right, to a joint or to some type of link, then we have disruption to the entire chain, whether that's proximal or distal to the actual injury. So as we look at this image on the slide, right, we can see that the ankle joint, we know that it's a stable joint, right? And so what we see in the parentheses is mobility. What that is saying is that the ankle joint is a stable joint. So most often, if there's compromise to the ankle joint, the goal of the treatment is to improve mobility about the ankle joint, right? So I'm trying to give you a clinical pearl. You can think about what the joint normally does. Then most often when that patient comes in to see you, they need treatment for the opposite of that. The ankle is a very stable joint. Oftentimes when there's injury, they become less mobile. An example would be an ankle sprain model where we have less dorsiflexion range of motion over time. So what's the goal for us as clinician? To improve dorsiflexion range of motion, increase range of motion and mobility about the ankle joint to restore it back to its normative state. We can take a more common joint that we're probably all comfortable with, the knee joint. The knee joint is a very mobile joint, right? It moves in 3 degrees of motion, massive amounts of knee flexion. Some people, if they have hyperextension moments, get increased knee extension. It moves in the frontal plane for valgus varus moments, or in the transverse plane, right, for internal rotational moments as well. So that knee joint needs to be mobile. It needs to be mobile to allow us to flex, to absorb shock. But when we're injured, oftentimes there's a need to increase stability at the joint, right? Because there's laxity. So we need to strengthen everything until our ligaments can heal, for example. As we progress upwards, we're talking about the lumbo-pelvic hip complex. So that's kind of where I want to spend a little bit of time. The hip is an extremely stable anatomical structure. And you might recall from lower extremity, the hip has the internal ligaments, right? Example, the iliofemoral ligament, the pubofemoral ligament, the ischiofemoral ligament. Those ligaments are going to have direct attachments to the femur, and it's going to really lock that femoral head into the acetabulum, right? And then in addition to that, we have even more mobility because we have the glute muscles, for example, the tensor fasciae lata, just naming a few, which also have attachment sites to the pelvis and the hip, which create a very stable hip joint. So oftentimes the hip isn't often dislocated. So when we see injury or dysfunction at the hip, most often the goal of treatment is to increase stability, right? Now the lumbar spine on the opposite hand of that is pretty mobile. And we can think of it in our ability to extend, in our ability to flex, in our ability to rotate. For the most part, it's a pretty mobile joint. And that's intentional because the joint just below it is extremely stable. So we have to have some give and take in the links that are associated with one another. However, anytime we have an injury to the lumbar spine, most often because it's so mobile, the goal is going to be to improve stability about that lumbopelvic hip complex. And so we're going to say, like the core, for example, oftentimes the goal of the core really is to create a more stable lumbar spine. So I hope that this is making sense, right? Remember, we talked a lot about the thoracic spine, and I said the thoracic spine is pretty stable, right? And it has to be stable because on the posterior surface, we have the ribs coming in to insert onto each of the vertebrae within that thoracic spine. If it's too mobile, right, we have maybe glenohumeral instability. So the stability is absolutely intentional. However, oftentimes, if we have a glenohumeral pathology, it's linked to the scapula or lack of scapular movement. And so the goal might be to improve mobility at the thoracic spine to get better glenohumeral joint mobility. So we can see that each link is either stable or mobile. And so then the opposite of that in rehab would be to either increase stability or increase mobility about a particular joint. And that's beautiful, right? Because then you have these corrective exercise pearls that you can think about, but knowing what each joint does and how it functions is extremely important as you become movement intervention specialists and as you progress into the next phase of the program. So the lumbopelvic hip complex is really the term that we should use as clinicians. However, to the general public, they most often refer to it as the core. And if I were to go back a few slides, I think I'm going to do that. If I go back to this original slide here, one of the things that you have to understand about the lumbopelvic hip complex, and you can see it in this image, is that there are 29 muscles that attach to that lumbopelvic hip complex, exerting forces in different directions with the goal of really creating a stable complex or region, right? And we talked about that when we talked about pelvis anatomy and the SI joint and injury to the SI joint. But you can see just in this image alone that we have the rectus abdominis, which has a distal attachment to the pelvis. We have the adductor muscles coming up and having attachment from the femur to the pelvis. We have that psoas muscle posterior to that. We have the erector spinae muscle. So we can see we have these 29 muscles coming together to create this integrated functional this functional unit known as the core or the lumbopelvic hip complex, right? So for that reason alone, anytime we have injury to the lumbar spine, we need to ask ourselves which muscles are going to be overly active, which muscles are going to become inactive. And again, that's going to drive your rehab as you start thinking about that, right? Essentially, we also have to think, okay, preventatively as prevention specialists, that lumbar spine, that core is integral, right? It is integral. Remember, we said it's a relay station, it's a fulcrum, right? It's a roundabout, right? All of these things are a fancy way to say that it's going to take forces from proximal, drive them down and relay them distally and dissipate the force, or it's going to take those gravitational forces and transmit them superiorly, where they're converted into energy, right? And if it cannot do that well, then those gravitational forces or those forces from the distal segment don't get transferred where they need to get transferred to. They don't get converted to energy. And so then we have inefficiency in certain movement systems, right? And an overcompensation might be, let's say, an impingement syndrome or a tendinopathy in the glenohumeral joint because the forces aren't being transmitted the way that they need to, or because we don't have enough mobility in that thoracic spine, right? And so now the scapula is working overtime. So the goal is to strengthen or at least maintain strength of the lumbopelvic hip complex. And when we do that, then we enable it to produce force, right? So force meaning maybe it's throwing the ball faster, maybe it's exploding from some sort of jump squat or for a layup, right? So we're allowed to produce force. I think more importantly, I would say that when we strengthen our core or the lumbopelvic hip complex, we're more efficient. We're able to slow down the rate at which forces travel, which is extremely important. It creates efficiency in terms of movement of load. And then I would say it helps us with neuromuscular control, proprioception, and balance, because this is certainly going to stabilize the hip on the pelvis or be responsible for stabilizing the hip on the pelvis, reducing the amount of forces that actually occur within the lumbar spine. When a patient has a weak core, you can identify them sometimes visually and aesthetically. Other times you might not be able to. We see that there's decreased stability, which compromises movement systems, both proximal and distal to that. There is a lack of force production and inefficiency in the way that the patient kind of creates the force. In other words, they will overuse other joints to compensate for the lack of control in the lumbopelvic hip region. And so as a whole, as we start thinking about the anatomy of the thoracic spine and the lumbar spine, we have to consider the pelvis or the ilia and the hip as well. And this image in the bottom right-hand screen really brings it home. We can see the patient kind of holding their hands. We can see that the center of gravity is central, so force is going to be dissipated the way it needs to be. But you can have a patient to the right of that person with the hat backwards, right? Standing with hyperlordosis, changing the instantaneous axis of rotation and pushing the forces more anterior. So it may very well be that we have sternal pathology or maybe even clavicular pathology because of the gravitational forces. So anytime we can strengthen our core or our patient's core or lumbopelvic hip complex, the more efficient they become in transmitting forces from the distal extremity, or at least gravitational forces from the proximal component of the skeleton. So one other thing that we have to talk about as we move into the lumbar spine in particular is this concept right here. So this is the lumbar spine. The lumbar spine is really close to the SI joint or the relay station in that it's the first point of contact for forces coming from the lower extremity to the vertebral column. So is it surprising that 70 to 80% of the patients that you'll interact with will experience some sort of low back pain in their lives? Absolutely not, especially those patients that have been active over a lifespan, right? The nice thing about low back pain or low back injuries or lumbar spine injuries, and really thoracic spine injuries on the posterior segment, is that acute injuries account for about 10 to 15% of those pathologies. So you aren't going to most often see acute pathologies, traumatic pathologies on the posterior segment of the vertebral column, which makes you have to be a good history taker when these patients come in, because most often when they come in, the low back pain or the thoracic pain is most often going to be associated with some sort of dysfunction to the lumbopelvic hip complex or some type of chronic pathology, right? Recent research just published suggests that low back pain is oftentimes associated with depression. So oftentimes, because low back pain can persist for an extended period of time, it leads to patients being less active over time, which increases their risk to suffer from depression. Now, we know that following the pandemic, that mental health disease or illness was on an incline and probably has plateaued now. But what we have seen is that any stressors, any increase in stress, any depression, for example, anxiety, actually prolongs the recovery from low back pain. So oftentimes with low back pain patients, the first thing that we assess, level pelvic hip complex, and then mental health status, right? Because the first thing that we want to do if we have a patient suffering from depression or anxiety is actually address that first. And that could be through a referral to a sports psychologist or a psychologist, psychiatrist, addressing that first before we really dive deep into doing the actual rehab. Now we're going to move into clinical anatomy of the spine. But like I said, I thought it was important first for us to really have a great understanding of the lumbopelvic hip complex, the kind of intersectionality between the upper extremity and lower extremity, and how the two are connected. Now we can dive deep into the very specific anatomical pieces that make up what we call the spinal column. So what I'm gonna do now is kind of turn off my camera and turn it back on when it's needed. So I'm gonna stop that video. And then what we are going to do is talk about the clinical anatomy of the spine. So what we want to do right now is first start with talking through the different curvatures of the spine. I think that's extremely important. The different curvatures of the spine, we can see them here, are going to be the lordotic curve, which is kind of an anterior displacement of the vertebral column. You have a kyphotic curve, which is really turned a posterior displacement or a rounded kind of curve. Then we have a lordotic curve in the lumbar spine, which is going to be, again, an anterior displacement. So we can see we have two anterior displacements, one in the cervical spine, the other in the lumbar spine. Sorry, the other in the lumbar spine. And then we have this kind of posterior curvature in the thoracic spine here. And what we can see is this is normal anatomy, right? That lordotic curve in the cervical spine, that kyphotic curve in the thoracic spine, and lordotic curve in the lumbar spine. The question that we have to ask ourselves as clinicians is, not every patient's going to come into us and have this beautiful alignment and this beautiful curvature, right? Most often what we see if a patient's coming in with some sort of low back pain pathology is there are deviations to the curvature. The first deviation, probably most common deviation, is a hyperlordotic curve. That can occur in the cervical spine, but we're not talking about cervical spine there, so we'll skip that. And it can occur to the lumbar spine. When we think about a hyperlordotic curve, think intuitively, since it's an anterior curvature, we're going to have an increase in the anterior curvature coming from the anterior, the lumbar spine. And so that can be tricky, right? If we have this lordotic curve, which increases its anterior curvature, the main thing that we're concerned about coming off of abdominal pathologies is some sort of like compression of the internal organs, for example, especially if that anterior curvature is heightened, right? But more importantly, what we can see is that as the spine moves more anterior, is allowed to sit in a more anterior curve, we can see that the instantaneous axis of rotation shifts, right? So where in a normal patient, that instantaneous axis of rotation would be centrally, right? That center of gravity would be central. We can see that the center of gravity has moved more anterior, which may, when we're thinking about transmitting forces, may transmit forces to the sternum, for example, or the lateral costal cartilage of the ribs. So we can see that that patient might, because they have more forces going to that costal cartilage, might suffer from rib injuries, because of the increase in the lordotic curve. The next prominent type of dysfunction that we see in the spine in terms of abnormal curvatures is a hyperkyphotic curve. So think this is an increased posterior kind of displacement or increased posterior curvature of the spine. So in essence, what you're going to have are pecs that are going to be really stretched, right? You're going to have maybe traps and rhomboids, which are going to be really contracted. And you have forces that are going to be, the instantaneous axis of rotation is going to shift posteriorly. So oftentimes you'll see compromises to the scapulothoracic rhythm. You might see direct fractures to the vertebrae in the thoracic spine. Big thing we want to do is stretch those rhomboids as much as, and traps as much as we can, and then maybe strengthen those pecs, right? The next type of abnormal dysfunction of the spine is going to be someone who presents to us with a flat back. So as you can see here, there's no anterior displacement. In fact, you have a decreased or no lordotic curve in the lumbar spine. patient still maintains that kyphosis like they're supposed to. In essence, you might actually get a flattened lordotic curve in the cervical spine. And so that also shifts the center of gravity, creating more forces that stay in the vertebral column that don't get generated or converted to energy, such as like throwing a ball and increasing speed and velocity. Next is sway back. So with sway back, what you get is an anterior kind of curvature to the lumbar spine and increase thoracic spine, right? So let me say it again. You get hyperlordotic curve. Sorry, here we are. Hyperlordotic curve and a hyperkyphotic curve. So imagine, man, this is a spine that looks like that. So you get anterior displacement, which means you might get some compression of the internal organs. Then you have a posterior displacement, which means those traps, rhomboids are pretty tight, those pecs are pretty stretched. And I think secondarily, what you'll see is the head move forward into an anterior position because the curve is so kyphotic in the thoracic spine. The last deviation that we can see in a patient is a scoliotic curve. That's going to be a lateral displacement, right? Most often of the thoracic spine, which, as you can see, has compensations at the lumbopelvic hip complex, which means as we transfer forces up the spine, the efficiency at which we do that is going to be impacted. So those are the different dysfunctions of the spine, and this is how you should define them for your board of certification examination. So here we are again with the skeleton model, because we're actually talking about the vertebral column. So we have the cervical spine, which houses 7 spine. We have the thoracic spine, which will house 12 vertebrae, and then we have the lumbar spine, which will house 5 lumbar vertebrae. And then as we move even more distally, we have the sacrum, which will house 5 fused vertebrae, and then we have the little coccyx distally, which will house 4 fused vertebrae there. So all in all, we have a total of 33 vertebrae within the actual spinal column itself. As I mentioned, sacrum down going to be fused, and then you have just proximal to the sacrum moving up to the cervical spine. These are by mobile, what we mean is they can move. They're not fused. They're independent vertebrae as we move through. And this is going to become important as we talk about the different spinal segments. So the cervical spine, the size of the spinal body and the way that it's made up will be different than that of the thoracic spine and that of the lumbar spine. So that's what we're going to move into next, is really talking about the anatomical differences between the spines as they exist, because knowing that will help you understand their role in force, either absorption or transference throughout the entire body. So let's go ahead and take a look at that. Here, what we have, I'm going to turn off the camera again. Here, what we have, and what you'll see here are the 3 different types of spines that we'll see. So we have a cervical spine body, we have a thoracic spine, and we have a lumbar spine, just to orient ourselves. We can see that the cervical spine is relatively small, relatively thin. Its spinal body compared to the other 2 is going to be small. And the size of the spinal body, really the size of the vertebrae, has to do with how much load it's going to actually bear. Cervical spine certainly is going to receive gravitational forces from the skull. So it's the amount of force or the amount of weight it's receiving is very minimal, right? Compared to the lumbar spine, which is receiving a lot of the forces from the lower limb and is like the focal central point for weight distribution. And that thoracic spine sits right in the middle. And so because it sits right in the middle, then it's going to be larger than the cervical spine, but certainly not as large as the lumbar spine, which shares a lot of the load and weight distribution within the actual body itself, right? As we look at the lateral view of the actual spines, we can see a couple of things that exist with the spinous process. So first, the spinous process on the cervical spine and the lumbar spine is typically shorter. The lumbar spine probably the shortest, cervical spine being second, and then that thoracic spine, we can see that that spinous process is relatively large. Remember, the spinous process is the most palpable part, right, of the vertebral column. So I wanted to make that very. So ultimately, as we kind of think about the different spinal bodies, the cervical spine here, that spinal body is very small in nature. And for C1, keep in mind that the vertebral body is actually absent, right? Because it's going to connect or make contact directly with the actual base of the skull. The vertebral body for the thoracic spine is going to be thicker. It's going to increase in size, obviously, as we move down or move inferior in the spine. And the reason for that is the reliance, the need to withstand some of the weight or forces being transmitted will increase as we move down the vertebral column. And then we have the lumbar spine, which the body is going to be large and thick. And again, that's the first stopping point for forces being transmitted from the lower spine itself. When we think about the spinous process, as I already mentioned, the cervical spine, it's pretty small. The exception is C7. In C7, it's going to be more long, like our thoracic spine. And our thoracic spine have the longest, probably most palpable spinous process. And they're going to project kind of downward. And I'll show you in just a second what that looks like. And then last but not least, we have our lumbar spine. And our lumbar spine, the spinous process is shorter, as you can see it here, but posteriorly projected. And we can see here, the spinous process is a little bit thicker. So these are thinner and longer, and the lumbar spine has a thicker, shorter spinous process. Why do you think that is? Again, it's all about forces being transmitted through the actual spine. If this was thinner, all of the forces being transmitted here, we might see more fractures at the lumbar spine than we actually do to begin with. Let's talk about the transverse process. We actually don't see it in this image, but maybe in the lateral view. Oh yeah, we do. So transverse process, we have on all of our, you see the transverse process here, you can see the transverse process here. What's very clear is that the transverse process is really short. Its major role is to create kind of this transverse foramen, and that is going to allow for passage of the vertebral artery as it leaves the cranium and enters into the cervical spine. So its major role, quite honestly, is really to create this foramen that we see here to allow for passage of the vertebral artery. The thoracic spine, on the other hand, you can see that they are more solid, they are longer, and we can see that they house the transverse costal facet, which serves as the attachment site for which structure? Someone tell me. Great, the attachment site for the actual ribs themselves. And then over here on the lumbar side of things, we can see that this transverse process is, I guess, more wide in the frontal plane, for lack of better words, and they're projected a little bit more posteriorly in nature. Again, your transverse process going to serve as attachment sites for ligaments to increase stability and mobility over time. And then you have in this image the vertebral foramen. So that vertebral foramen, it's circular for a reason. What would the reason be? Someone tell me. Good. It's going to be the space that the spinal cord actually moves through. If you all can't see that, imagine the spinal cord moving through that actual space. So on this image, what I really wanted to talk about is kind of the neural arch, which is this structure. And the neural arch is comprised of two kind of bony landmarks. The first is the pedicle. The pedicle is the bony anatomical structure just posterior to the vertebral body, right? So this is the vertebral body. We can see right here, just posterior to that, we have the pedicles. The pedicles create the, I would say, the most anterior portion of the neural arch, whereas the most posterior portion of the neural arch is going to be formed by the lamina, which we'll talk about when we're referring to what am I thinking of? The spondy pathologies. Oftentimes when there is a fracture and it's a spondylolisthesis or spondylolysis, most often that defect occurs to the lamina, or the space that we call is the pars intra-articularis. And so the pars intra-articularis, even though people think it's the lamina, it certainly is. It's really an extension of the lamina that exists in between. So you can kind of see it here, that superior process of the facet. So it's going to kind of exist in between the superior and inferior process of the facets themselves. And this is a common fracture site. Does that make sense? It's kind of where the bone is changing its shape. So it makes sense that it's at its weakest. And so of course it will fracture off most often. Some people in the research oftentimes think of a spondylofracture to the pedicle. And even though a fracture can happen here, we're truly talking about a spondylolisthesis. It's most often to the lamina, in particular the pars interarticularis, right? So that would be the kind of bony anatomy of the spine. If we go back a slide, I'll go back a slide here. You can see that each spine itself has a different orientation, different sizes, and that's going to be based on the amount of weight that is coming through it and the number of forces or the amount of forces that would travel through it on pretty much a daily basis, right? And so since gravity is really the only force, the skull, most oftentimes that cervical spine is going to be a lot smaller. And then if we were to dissect the lumbar spine, you would see that it's thicker and larger because it's going to be the first relay station for force transference from the lumbar spine. Again, the key things here are looking at what things make up the actual neural arch, which is responsible for protecting the spinal cord. Even though it lives within the vertebral foramen, it's created by an arch. And so the pedicle is going to be responsible for creating the most anterior portion, and then that lamina is going to be responsible for creating that most posterior portion of the arch. We're going to talk about two different terms. We're going to call them sacralization and lumbaralization, and their name kind of implies which bone is being fused. So let's talk through this. If you have a sacralization, this occurs when the fifth lumbar vertebrae becomes fused with the actual sacrum itself, right? And so an example of that would be here. So we can see lumbar 1, 2, 3, 4, and then we can see that 5 is actually fused into the base of the sacrum, right? The normal model would look like this, 1, 2, 3, 4, 5, and then you'd have S1. But in this model, that lumbar spine number 5 becomes sacralized. It becomes fused with the sacrum. So we can see L5 has merged into S1 and they've become kind of one unit. So instead of having 5 lumbar spines, we have 4. And most of these patients, it's congenital always. Most of these patients can live life without pain as they become active, essentially, depending on the amount of load, particularly jump sports. You might see more lumbar spine issues just because you have one less spine for the force to travel through. The opposite end of that is lumbaralization. Lumbaralization occurs when the first sacral vertebrae fails to unite with the remainder of the sacrum. In other words, S1 doesn't fuse to S2, and so we don't have those 4 fused sacral bones. So what you get is an L6 instead of an S1, like we see here in this image. So L4, L5, this will be L6. It'll present like an L lumbar. In other words, it'll be thick and wide and beautiful. And then we'll only have maybe 3 fused sacral bones, right? And this is kind of key. If you think about the role of the sacrum in first transference from the lower extremity, right? That sacral base, that S1 is extremely important because it's wide. It's going to allow for the relay station to occur, right? And then to transmit forces up to the upper extremity. So you can have sacralization or lumbaralization. For the most part, patients will present to you pain-free, but every now and then if they participate in sports which require a lot of sacral movement, for example, or a lot of lumbar spine movement, you may see that they will present to you, and there's absolutely nothing you can do about this, right? Unless of course you do like a sacral fracture where you separate, but that's probably more traumatic than not. Most of these patients are pretty functional in their ability to participate in sports. So as we move even further, let's talk about the intervertebral disc. The intervertebral disc, as you can kind of see it here, is probably the thing that the vertebral column is most often known for. So let's spend a little bit of time here giving it its credit because I think it's important. It's probably the #1 pathology that we'll actually see in the clinical setting. So when we think about an intervertebral disc, the first thing that I want you to think about is they are going to be found in varying thickness throughout the body, right? Remember, if we talk about the proximal portion versus the bottom portion of the cervical spine versus the lumbar spine, the disc is going to be a lot thinner in the cervical spine because there's less forces being applied to the cervical spine. The, I guess, exception to that, some of you will say, is like if a patient spends a lot of time on their head. So a gymnast would be an example of that, for example. But for the most part, discs are going to change in size as we progress and get larger or thicker as we progress from the head all the way down to the lumbar spine itself. Here's what they do. Think of them as kind of the meniscus. They are going to increase total range of motion availability in the spinal cord. So they are responsible for allowing us to flex, to extend, to rotate. But more importantly, like the meniscus, they are major shock absorbers, particularly of longitudinal forces. So think up and down, sagittal plane forces, and rotational or shearing forces across the spine. So they play a major role, not just in shock absorption, but also in allowing us to move into the ranges of motion that we have within the spine. The disc itself is kind of comprised of the following things. So the first thing that it's comprised of is this annulus fibrosus, which is this kind of dense, thick outer layer protective, right? It's going to protect the inside, which is the nucleus pulposus. That nucleus pulposus is a flexible inner layer, and we need fluid to kind of move a little bit when we load, right? To squish, but we need that external, right? This external layer to kind of prevent the fluid from seeping out into the spinal cord, for example, or outside of the body. So there's a give and take, is the way that I kind of like to think about it. There are, as it's listed here, 23 intervertebral discs. There isn't a disc that lives between, obviously, the skull and cervical vertebrae number 1. And there isn't a disc between cervical vertebrae number 1 and number 2, because remember, that's the axis and atlas. They need to be able to rotate across one another to allow the skull to move. So those 2 levels don't have disc, but every level thereafter does. When you're referring to a disc pathology, one of the things that you want to think about is, how do you name that disc pathology, right? So let's name the disc pathology. In fact, I'm going to give you this here, and I'm going to take a little bit of a step back. So we have L1, L2, L3, L4, L5. The name of the disc has to do with the 2 discs that it lives in between. So if this is L1, L2, this disc right here is the L1, L2 disc, right? If we're looking at L2, L3, then this is the L2, L3 disc. And if this is L3, L4, this is the L3, L4 disc. We're looking here, L4, L5, this is the L4, L5 disc, and it's the site for most disc herniations if we're going to see it. And the other one is L5S1. So this will be the L5S1 disc. So these 2 discs most often are the ones that we see injured most often in the clinical setting. So as we think about the disc and its role in terms of shock absorption, in terms of allowing us to really move through ranges of motion, I think it's also important to kind of really think about the 2 anatomical structures, which are important for kind of maintaining the disc structure, integrity, and the shape. So that annulus fibrosus, as I mentioned, it's really tough. It has like multi-layered fibers that kind of cross in different directions, forming kind of like this crazy X pattern. And so ultimately, its major role is to be a little elastic and allow the fluid to displace a little bit, but certainly to come back to its resting shape and to prevent that nucleus pulposus, the fluid, the jelly-like fluid, from moving out into either the spinal canal mainly, but also just into the vertebral canal itself, right? The nucleus pulposus, however, is going to be like really, like if we're looking at this, it's going to be really highly elastic. It's going to be mobile. It's going to be semi-gelatinous in nature. It's made up of about 60 to 70% water. The other is kind of gelatin. So it's like squishy. Think of it like Jello. The beautiful thing about having a high water content is that it really makes it resistant to compression. In other words, it is capable of being deformed and then being reformed or moving back into its normal space, right? Now, as we get older, the hard part about the nucleus pulposus is that it becomes dehydrated, losing its ability to deform and then reshape. But ultimately, these 2 anatomical structures make up our intervertebral disc. And this is extremely important because you can have compromise most often to the annulus fibrosus, so like a stretching, which then allows the nucleus pulposus to spread wider and not reform and create that kind of centralized disc that we typically would see. So on the next slide, what we're going to do is talk about the characteristics. And as I said right here, that annulus fibrosus is a highly structured, like layered structure. You can see the crisscrosses. We're really trying to create a thick fiber-like structure which protects the inner portion of that, right? This portion right here, which is capable of expanding, but then also centralizing or coming back, right? Now, for sports that cause a lot of torsion and or shearing across the lumbar spine, The nucleus pulposus despises that. In other words, it's what causes or is responsible, those torsional forces, those shearing forces. Those are those forces that are responsible for kind of causing the disc injuries that we most often see, or the discogenic pain that presents to us in the actual clinical setting. So we've talked about the disc. Our next stop is going to be with ligamentous anatomy. The first ligaments that we're going to talk about, largest, probably longest in the vertebral column, are going to be the anterior and posterior longitudinal ligaments. And we'll start with the anterior longitudinal ligament first. The anterior longitudinal ligament is going to span the entire spinal column. It's going to be thickest at the lumbar spine, and I'm sure that makes sense to all of us, right? It's going to be thickest because of what? The loads that get transferred, right? The loads and the force that go through the lumbar spine make it essential that our anterior longitudinal ligament be thicker in the lumbar spine than anywhere else in the vertebral column.